I'm not 100% sure. So basically, I don't know about Doppler. So basically, if you do take a blood pressure, you'll get like one number. Where you like that top, like that systolic number, because they don't, their blood pressure on an LVAD patient is just consistent because it's just constantly flowing. It's sort of like a pool pump, okay, as opposed to like your traditional thud thud or lub dub, of the heart. So an LVAD patient will be usually awake and talking to you, and they'll be complaining. If they're complaining of something completely else, like, oh, I've got toe pain, then the LVAD's kind of a non-issue. Usually they have like the setting on the screen of what, like, the PSI or like whatever it is that they're expected to be at. If you have an LVAD patient who is unconscious, almost number one reason that LVAD patients will go unconscious is there's an issue with the LVAD. So either the battery has died or they're severely hypovolemic. Okay, so like the worst thing as a GI or as an LVAD patient is like a GI bleed, okay, or severe dehydration, something like that. So if you have one of those issues that you can correct, then you need to do that. Like if the battery's dead, you just put a new battery in and charge them back up, and hopefully they start running again. The newer LVADs are CPR safe. Okay, I know back when they first introduced LVADs, they're like, do not do CPR, because they were afraid that you were going to pretty much take all of the mechanisms, all those like tubes and hoses that are kind of sticking out of the heart, and just disconnect them. But the newer LVADs, it is supposedly safe to do CPR. I'm not sure about with a Lucas device or like another mechanical CPR device, but hands-on CPR is approved. I don't know if that answers your question, but for the most part, if you can even just document like patient has LVAD, patient is awake and alert, unable to obtain vital signs. They're good.
A quick follow-up to that, because I have had an LVAD, and so I have that experience. I'm presuming then that an LVAD is pretty much a BLS patient, because drug protocols are not going to work on that heart, are they?
So drug protocols will not work, but they potentially could be. So if you have like an anaphylactic, an LVAD patient who also happens to be anaphylaxis,
Sure.
that becomes an ALS job. If you have a LVAD patient who is also now hypovolemic, that becomes an ALS job. If it's something completely unrelated, like they broke their hand or something to that effect, that can totally go BLS. Oh, if you do happen to put the patient on a monitor, you will see what their underlying rhythm is, even though it doesn't really matter. So a lot of these LVAD patients might show with like a sick sinus syndrome, which is like a really kind of sad, weak-looking like sinus rhythm, where like beats are missing, the QRS is really tiny, and there's just not a lot of quality electrical movement going on. So they might show with that. They might have really bad AFib. It could be almost anything. So if you wanted to document that rhythm, you're totally like warranted to do so. But as we said, it doesn't really mean anything because that pump is going. You can auscultate the chest to make sure that you hear the impella, that little tiny motor that's going to like make the blood move around. That would be a good thing to do also, especially if they're unconscious for some reason.
Thanks, Nicole.
No problem. All right. Any other thoughts, questions, concerns before we get going? Yes. Whoever has that EKG textbook with examples, please let me send that over to me. I don't know who's on iPad. Cool. All right, guys. So,
Nicole, it's me.
Okay, yeah, if you could send that over, that would be awesome so I can distribute.
Okay, I'll just have to talk to you after class. I'm not sure how to send it over, but
Okay.
it was really helpful for me.
All right, sounds good. We'll make it work. All right, so 12 leads. So obviously you're going to get a little bit more practice with the 3 leads, and that's going to help you kind of in the 12 lead interpretation, because the first part of 12 lead interpretation is knowing what your underlying 3 lead is. Okay, what's your underlying rhythm? If you don't have an underlying rhythm, you're really going to potentially be a little bit lost to the 12 lead, or if it's asystole, in which case you shouldn't be doing a 12 lead. You don't need to confirm that. It's flat, it's good. So we talked about this a little bit previously, right, where your placements are for your excuse me, for your precordial leads. The precordial leads are looking directly at the heart, right? So like if you took a camera and you placed it right where like this electrode was, and you just took a picture straight at the heart, that's the wall of the heart that it's looking at. It doesn't need another lead like the limb leads do. It's just a straight focused identification, okay, of that part of the heart. Which means that if your placement is not correct, you're going to be looking at the wrong part of the heart. So if you take V1 and you put it all the way up here at the manubrium, you're not going to be looking at the septal wall of the heart. You're going to be looking at the atrias, okay? So it's very important that you make sure that you're placing the 12 lead appropriately. Now, the first few times that you place it, it's completely acceptable for you to palpate and just kind of determine where the ribs are. However, your anatomical landmarks, it's a little easier with men than women, is that nipple line, right? So V1 and V2 are approximately at that nipple line, and then then you place V4 just kind of below the nipple at the mid-axillary. V3 goes in between on an angle, and then V5 is anterior axillary, and V6 is mid-axillary, all along like the kind of same straight line from V4. It does curve up a little bit to follow the ribs, but depending on how beefy your patient might be, it's going to help you kind of determine where those anatomical landmarks are. Had a medic once who decided that he's been a medic for a few years, and he still wanted to palpate the patient's chest every single time that he put a 12 lead on. You should be able to get that muscle memory down. If you don't, you're not doing enough 12 leads. Anyway, so 12 lead monitoring gives you a little more information than your limb leads. On a very rare occasion, you will be able to pick out tombstones like on a 3 lead, in which case that patient's probably doing very, very poorly. But 12 lead does help you a lot when it comes to like kind of determining a more precise rhythm. Left bundle branch blocks, okay? Left and right bundle branch blocks, you can find out from a 12 lead. The electrical axis, okay, right? Because you need more than one lead in order to determine the axis, and having a little more information helps a little bit, clarify it a little bit more. And this is really where we are in terms of what you're learning right now, okay, is determining where myocardial ischemia, injury, infarction is due to ST segment or T wave changes, okay? This is really what we primarily use 12 lead monitoring for. It has a lot more robust use. Like if you have a patient who is in a potential VTAC, okay, you can determine the difference between VTAC or an SVT with aberrancy by doing a 12 lead. And I'm going to tell this story real quick. One of my medic students from the last class, he texted me a couple weeks ago, and he was like, I just wanted to thank you so much for telling us that if you are ever uncertain about a rhythm, to make sure you do a 12 lead with it. He had a patient who the 3 lead looked like that it was a VTAC with a pulse, and he confirmed with a 12 lead, and the 12 lead did not read that it was VTAC with a pulse. It was actually ended up being SVT with aberrancy, and he could tell due to the axis deviation and all that other stuff. So he was able to more appropriately treat the patient because of that added information, rather than treating it like VTAC with a pulse. Granted, there's not a huge differentiation between the protocols, but in terms of like how you walk into the hospital and you're like, hey, it wasn't VTAC, it was SVT with aberrancy, that will determine their course of treatment in the hospital. Okay, that will make a significant difference there, because rather than them going for potentially cardioversion or getting a pacemaker or an ICD placed, this patient might be getting an ablation, okay, because it's a completely different mechanism that's causing one versus the other. Another view of 12 leads and how the precordial leads view the heart. Okay. If anyone has read the Dale Dubin book, he likes to use actual pictures of a camera and to give you the idea of how it's moving around the heart. So we talked about this a little bit before in the last lecture, that the left ventricle is a little more anteriorly located than the right ventricle, right? It's kind of twisted just a little bit. So when you're looking at these precordial leads, they're primarily looking at the left ventricle. And we're going to talk about why that's significant in a little bit when we talk about right-sided 12 leads. Your normal progression of the QRS complex, right? We talked about this again before, right? That we call it the R wave progression. I'm doing air quotes because I just realized you actually can't see me. V1 and V2 are primarily negatively deflected. Okay, V3 and V4 look normally are biphasic, right? So you have part of that QRS complex is above the isoelectric line, part of it's below the isoelectric line, and then V5 and V6 are primarily positive deflections, okay? If you have any sort of differentiation between that, where like maybe V1 and V2 are positively deflected, there's something else going on and you need to look more closely at the EKG, okay? Or you need to make sure that you put it on the patient correctly, okay? Sometimes people have little tiny strokes while they're taking care of the patient, right? Lefts and rights sometimes are very challenging. It's especially if you work on a volley truck where you have access to both sides of the stretcher as opposed to just the left side of the stretcher. It can really throw your head for a little directional loop. So just make sure that all your leads are placed in the correct location. So we also briefly discussed this, but I think it's a little easier when you have a picture. So your heart has a vector, right? So a vector in like physics and stuff is the direction of a force. So if you think of the force as the electrical motion in the heart, it primarily moves from the right down to the bottom, to the top right to the bottom left, okay? And that's a positive deflection, a positive electrical motion due to depolarization, right? Because we talked about how in order to depolarize the heart, it needs to go to about positive, 50 millivolts or whatever that precise number is per, which is dependent upon individuals. So it moves from the top right of the heart, the SA node, and it goes all the way down into the bottom left, into the Purkinje fibers. Meanwhile, there are some smaller vectors, right? There's some vectors that move this way, go across to the atria, and some that go this way into the right ventricle. But your primary, like if you added up all the directions, the major sum of the electric moves down towards the left, okay? In order to determine if this is going correctly, that means we have the vector, right? It's kind of like, if you look at this right here, is a picture of the heart, right? It starts here and goes down here. If electric is going in the opposite direction, we call that an extreme right axis deviation, right? That means the electric's going the completely wrong way. First thing you should do is make sure that your limb leads are on correctly, okay? Without a doubt, first thing you should check. So now imagine if you have a patient who is extremely pregnant, right? And that gravid uterus is pushing that heart up. Usually it will push it up off to the left a little bit, okay? So you might see a patient who their axis is over here on that left axis or slight left axis deviation, okay? That's totally normal in certain situations, like, as I said, a pregnant lady or an obese gentleman, patient who has maybe severe liver cirrhosis, right? Because that liver sits right under there and can kind of shift the heart a little bit, right? So instead of it going this very normal trajectory, it's kind of going off to the side a little bit. Now, if you have a patient who is experiencing injury or infarct, dead tissue cannot transmit electric. So imagine like this part down here where the bigger arrow is, that whole big arrowhead, imagine that's dead tissue. That means you have less electric moving down this direction. So it's going to skew the axis because this strong pull isn't occurring. Okay, so if this part all down here is dead, now you might have a right axis deviation because all this muscle is the only thing that's transmitting electric, and this is all dead. Okay, does that make sense?
Yeah.
Yeah, we're understanding that concept. So if a tissue doesn't transmit electric, it cannot pull the vector into the correct direction. All right.
That can be seen on EKG, right?
Yes, and now this is where we're gonna, ready? Here we go. So if we're determining what the axis is, we need to look at two leads, okay? So you're looking at lead 1 and lead AVF to determine your axis. Your normal axis has a positive QRS deflection in lead 1 and in lead AVF. Okay, so both of those should be positively deflected. If they are not, now we're going to kind of put it into this clock. Okay, so your left axis deviation, this is what we're talking about right here in this slide. Okay, you have a positive deflection in lead 1 and a negative deflection in lead AVF. Okay, AVF, you're looking at this bottom part of the heart. So if you have an extremely large left ventricle, right, that's maybe transmitting more electric than it usually does, it's going to pull that whole vector and kind of swing it up to the left. Okay, does that make sense?
Yep.
Okay. So if it's swinging it up to the left, then it's going to be up here in this left axis. Things like obese patients, pregnant patients, we talked about that. Now, other things that could cause that, right? An inferior wall MI. Okay, an inferior wall MI usually happens here and that right part of the ventricle, right? So if this is not compensating for pulling the vector more into this bottom range, it's going to swing it up to the left and you'll have a left axis deviation. If you have a left bundle branch block, right, and the electric is not going down the septum, it's going from cell to cell to cell, it's going to pull all of that electric off to the left ventricle and it's going to cause a left axis deviation. Okay, why would a right-sided tension pneumo cause left axis deviation?
And push everything to the left.
Perfect, right? So now you're kind of taking this heart and you're crushing it to the left, sort of in a similar way that we talked about how the gravid uterus will push that heart up. Same thing, the tension pneumo is going to physically move the heart and change the axis. Okay.
I'm sorry.
No, go ahead.
So basically, like if there's something going on with the right side, you're going to see left. You're going to see deviation to the left. If there's something going on the left, you see deviation to the right.
If I'm going to kind of clear that up a little bit more. If there's something going on where the right side is not generating electric, then you'll see a left. Because if you have hypertrophy, so like if you have a patient who has really bad untreated hypertension, even if the right side of the heart is healthy, it's still going to be a left axis deviation because it's just more muscle mass changing that vector. But yes, essentially that's the root of it. But if you have too much left, you also don't have enough right.
Gotcha.
Okay.
So when would you have a right deviation then?
Well, here we go. Thank you for asking. So if you have a
I'll lead you into this.
Thank you. That was the perfect segue. So if you have a patient who's usually the most common or most frequently seen issue is if you have some sort of damage to that left ventricle, commonly seen in a lateral heart attack, okay, that lateral wall. So if that lateral wall is damaged and is not transmitting electric, that right ventricle starts pulling all the electric to its side. In this event, you will see a negative deflection in lead 1 and a positive deflection in AVF, the complete opposite of a left axis deviation, okay? Again, same thing if you have like a left-sided pneumo, okay, it's going to push the heart down and off to the side. Why would chronic lung disease cause a right axis deviation? Let's see what critical thinking skills we have today. Hope you all caffeinated. Nope, no one caffeinated.
Are you smoking?
Nicole, I just have a guess.
Go ahead.
Would it be because if you have lung disease, one of the lungs isn't working as properly, so you'll naturally compensate by going to the other side?
Sort of, but what's the lungs effect on the heart? Say that
Your
again.
heartbeat pumping harder because like
Keep
one
going.
lung is not, like I said, one lung's not effectively working. So like to get the oxygen to your body, your left ventricle is going to be pumping a lot harder.
Your right ventricle.
Sorry, you're right.
Yep.
Yeah, sorry.
There you go.
Thank you. Yes,
Yes.
sorry. Right ventricle.
So yes, that's the basic idea. If you have some sort of chronic lung disease, either if you're missing a lung where your heart has to work harder to move oxygen around, or you have something to the effect of like COPD now, or even pulmonary hypertension, right, where that normally very chill, small, low pressure circuit is now a very high pressure due to either overinflation of the lungs due to COPD or high levels of restriction in the pulmonary arteries. That right ventricle is going to have to work extra hard to pump blood to the lungs. And when it has to work extra hard, it gets a little more muscular, which means now it's generating more electric, which is it's skewing the way that the electric, travels through the heart. It's also common, a right axis deviation. If you have anyone under the age of like 21, don't be concerned, okay? It's usually a normal variant in younger children, just based on how the heart develops. If you also have someone who is extremely thin, you just have really good access to the view of the electric, so they also might have a bit of a right axis deviation, okay? But again, your primary, if you have a patient who has any sort of chronic lung disease or pulmonary embolism, that same concept, where that right ventricle is straining to get blood to the lungs, you're going to see a potential right axis deviation. So if you have a patient who's like, I have this this focal pain and I'm having a hard time breathing, right? And you put them on the EKG, you might see the, quote unquote traditional strain pattern from pulmonary embolism, but one of the most kind of hallmark signs is going to be that you might have a right axis deviation. Okay.
Nicole, and so chronic lung disease would increase preload. Is that what it is?
Yes, it's increasing preload and it's also increasing right-sided afterload because it's pushing against more pressure on that side.
Because you have the pulmonary hypertension, so it's when it's trying to, it's going to pump harder to try and overcome that.
Yes, exactly.
Gotcha.
So it's just like when you go to the gym, right? You go to the gym, you're like, I'm going to pick up this 10-pound barbell and do bicep curls. And then you're like, all right, this is easy. Then you pick up the 15 and then the 20. It's like sort of the same concept, but the heart, and as you start to see gains in the gym, your heart's seeing the same thing, except now it's pushing against that pulmonary afterload, that tension in the pulmonary circuit, where now it's like, all right, I can lift 50 pounds with my right ventricle, but it's totally beefy, bro, but it's not necessarily a good thing because your heart starts to get weak after a while. It's like dudes who do steroids and get really beefy and then stop taking steroids and look really flabby. That's essentially what happens when your heart has hypertrophy.
So don't do steroids, or
Don't do steroids. Don't do the anabolics. If you need to do the respiratory ones.
So Nicole, if I'm understanding that correctly, just from the electrical deviation standpoint,
Mm-hmm.
if we're seeing something that is completely opposite, that's an extreme, and then we have something like where one lead is showing positive, one negative, where it should be the exact opposite, that's something a little less of a deviation.
Yes. You don't very frequently see the extreme right axis.
Okay.
If you see an extreme right axis, you are most likely looking at like a VTAC. Okay? All right, cool. So now let's all kind of putting it all together, right? This is what a normal 12 lead looks like. Okay? This is what kind of what's your underlying rhythm here?
Regular sinus.
Sinus.
Good. It's a sinus rhythm. Use of the words, like we used normal sinus or regular sinus, and kind of in the whole vein of social justice, we don't always like appreciate those because, or normal anyway, because what's normal, right? So regular sinus is like the, because you're describing the regularity of the rhythm, right? That it, it's a one beat every second or something to that effect. So if you're going to use that, I would suggest leaning more towards regular rather than quote unquote normal. I'm air quoting again and you still can't see me. But if you look, first thing you should check, right? Do I have P waves? So here we go. We've got some P waves. Are the P waves married to QRSs? Yes, they are. Fantastic. Is my rate slow, medium, or fast? Right? So if you look at I got one here, right? So this QRS falls right on this big box. So 300, 150, 100, just under 100 beats a minute, probably in like the 90 to 95 range. And then you look at it and okay, my QRS is sexy. Are they tight and upright or down, depending on what part of the EKG you're looking at? Yes. Fantastic. Do I see anything that makes me go, oh no?
Is there an axis deviation in V1?
Say that again?
Is there an axis deviation in V1?
So if you're looking at axis deviation, you're going to be looking at lead 1 and AVF, where lead 1 should be upright and AVF should be upright. So here's your lead 1, it's upright. And here's your lead AVF, it's also upright. In V1, I would say you might have the potential for the beginning of a bundle branch block because it is a little wider, but it's still within your normal, so it's not a bundle branch. You do have normal R wave progression, right? So you have your V1 and V2 are negative, V3 and V4 are biphasic, and then V5 and V6 are upright. Okay? I usually like to say, like, if you look at an EKG and it makes you go, oh no, or it gives you pause, that you should really check your patient and then figure out what it is that you're looking at. So, another quick review of your bundle branches, since we kind of brought it up. So, if you have some sort of damage here in the right bundle, okay, it means that the electric is going down the expressway and it's innervating that and depolarizing that left ventricle with no issue, okay? However, this electric here is going cell to cell to cell to cell in order to depolarize the right ventricle, okay? So, look at lead 1, it's upright, and look at lead AVF, which is also upright. Let me just go back real quick. Normal, it's a normal axis, okay? Now, if you look at leads V1 and V6, in lead V1, you're going to have this bunny ears look, okay? So, as the electric is going really quickly down here, it's generating this part, and then as it's going slow from cell to cell to cell, it's generating this secondary wave, which is kind of like broad and slurry, because as we said, it's not going down the normal pathways in the heart, okay? Same thing happens here in V6, but because you're looking at it from a slightly different angle, it looks a little bit different than your bunny ears. In V6, you get what they call like this slurred S wave. I like to say, go home S wave, you're drunk, because it's just like a smudge up into the T wave. It's usually, the appropriate indicator that you have a right bundle branch block. Right bundle branch blocks are commonly relatively benign. A lot of people don't even know that they have them. because the right ventricle is a smaller muscle mass and is pumping against a lower pressure because of the pulmonary circuit, it's really not causing, it doesn't usually cause as much of a significant issue as a potential left bundle branch block is. Because the issue is if the cell to cell to cell is not as effective, you're losing a bit of your push and that contraction against the afterload. Because it's only on that low pressure side, it's not as noticeable because, as you said, that right-sided afterload is not as significant. Questions?
Mine doesn't really have to do with a bundle branch block. It's
Okay.
more like patient assessment, I guess.
Okay.
So say you have like a patient where you're suspecting a pneumothorax.
Mm-hmm.
Can you use a 12 lead to, like, as that extra step to confirm that you have the pneumo because of the axis deviation?
You could, absolutely. That axis deviation could give you a confirmation, especially if it's, like a COPD patient or someone where you're having maybe a hard time hearing the lung sounds as it is. It will potentially give you more information than just listening alone. That's a great idea. Jonathan, I saw you unmute for a second. You have a question?
No, I just I forgot that I was on, like I wasn't muted in.
Okay,
TV
no
going
problem.
on in the background. I didn't want to be distracted.
No worries. All right. So, looking here, right, now you have this is what a right bundle branch block looks like as a full 12 lead as opposed to just like individual complexes, right? So here you can see in V1 you have that bunny ears. Here in V6 you have that slurry looking S wave, right, where it's like, hey, T wave. And you kind of see throughout where you have like a broadening of that QRS, okay? It's not as sexy and tight as it is in your original, right? So see, look how close that QRS is. It's going out on a Friday night. This one, it's not going out on a Friday night. This is like it's coming home after a Friday night and it's having a little issue, okay, right? It drank a little too much and now it's a little sloppy, okay? That's kind of how I kind of determine it. A lot of times your 12 lead will give you a little reading of what's going on. Don't always take that for granted, okay? Like you should 100% be doing your own interpretation. Because sometimes it'll pop up some stuff and you're like, what are you looking at, right? Especially if you have like a bundle branch block, sometimes it'll pop up like...
You mind going back real quick?
Sure.
Let me
Where?
take a picture. Just one.
Here?
Perfect. Give me 2 seconds. Thank you.
No problem. So a left bundle branch block sometimes would be like acute MI suspected, and you're looking at it going, this is just a left bundle branch block machine. Calm down. It's okay. But now if you look at your, right, you're going to look at your axis as well because it's always good to practice. So here in lead 1, you have a primarily positive QRS. Here in lead AVF, you have a primarily positive QRS, but you do have a little biphasic, okay? So this might be heading towards a right axis deviation, okay? Or a left axis deviation because it's kind of coming down into this this side here, right? Because now you're having all that electric is being skewed, so it's not a perfect axis, but it still falls within the appropriate realm. Now, if you look up here, it does say normal sinus rhythm with a first degree AV block. So let's see if we can find a QRS that falls on the line. Here we go. It's this one's nice and close to that line, right? So what is the rule for a first degree AV block? How far away from the QRS does the P wave need to be?
More than point. Yeah, more than 0.2.
0.2, right? Because a large box is 0.2 seconds. Perfect. Both answers super correct. So if you look right here, he's falling on that big dark line. Here's your next big dark line. There's no P wave. Your P wave's hanging out in the next one over here. That's just in this lead. If you look over here, same thing, right? The P wave is all the way over here in this other box.
Can anybody else see you marking where you're pointing to?
Can't.
No?
I can't.
No.
Nicole, I think if you hit the pointer, when you have that little menu pop up, if you hit pointer,
Nope.
I think it'll happen.
Pointer. Hold on.
Yeah.
No,
Like
it
if
doesn't want to
you
pop up.
on the bottom left, a little menu pops up.
Ooh, exciting. Let's see if I can find it. Nope, that's not it. Actually, hold on. Give this back. All right, hold on. I'm going to move to the next screen because it's giving me a hard time now. So, all right. In the video, it should have the pointer. So if you are like super confused as to why I'm talking and pointing and you're not seeing anything, that would be helpful for you guys. Bourget. All right, now it's not. Now that menu's not popping up, so I'll give it a moment and see what happens. So now if you we talked about how the right bundle branch block means that the right ventricle isn't getting the electric as quickly as it should. Now you have the left bundle branch block, which means that the left ventricle is not getting the electric as quickly as it should. Okay, so now it's going from, aha, I got it. Hold on. Nope, I lost it. All right,
Oh,
so
there we go.
there we go. All right, so you have this brown. That's a useless color. All right, so you have this this block here. Usually, this block is caused by some sort of ischemia or injury, right? So instead of it going down the expressway and that left ventricle getting its electric really fast, it's going cell to cell to cell, and it's going the slow, service road way to get to all of the cells of this left ventricle, which means that you're going to have this, because like that left ventricle is the workhorse and the more muscular part of the heart. You're going to have this like really slurry, bizarre looking QRS complex. Okay, so in V1, when you have a left bundle branch block, it's going to be like big and deep and like just awkward looking. Okay, but your R wave progression sort of stays the same. Okay, you have a little less of the biphasic in V3. However, here in V6, you have, I love this phrasing, the broad and clumsy R wave, right? So, we talked about the bunny ears in a right bundle branch block. This is more like those like little bear ears, right? Those little cute like baby bear, like tiny, small, rounded ears, rather than big pointy ears. You might have a little more pointy ears in certain situations, but for the most part, it's this kind of like slurred looking vibe. No, now it won't let me. Come on. Now it's too much. Oh, now there's just like yellow all over the place. That's exciting. Let me see if I can get rid of that. Cool. All right. So if you look here, this is what a 12 lead with a left bundle branch block looks like, okay? So see here you have V1. Can you see the pointer?
It's negative.
No.
Don't see a screen at all now. Oh, it came back.
I don't know. Having a moment, apparently. So here, right, you have this big...
There we go.
There we go. Oh, wow. I don't know what that is. It's an adventure today. So, right, you have this big kind of slurred V1 and this notch top. You can kind of see right here, right? Pretty decently. You can see that notch, right? That notch here in V6. And you might end up with some really funky looking bundle branch blocks because it also might have like a hemi block involved. Well, I've seen, so if you kind of look right here where it's got this kind of step look, I've seen bundle branch blocks where this is like all like you've got like 4 different bumps going on and it's like a almost two full big boxes long. You're like, what is going on? It's like it's just a lot sometimes. But you'll get used to kind of picking it out. Basically, if you see something where you're like, what is that, right? Because here's your, oh, hold on. If you go back to, I'm trying to, hold on, talk to myself like, your right bundle branch block, it's like, okay, it's a little funky, but it's not too bad, right? If you print it out and you're like, whoa, what is going on here, right? For the most part, you should investigate to see if it's a left bundle branch block. Because if it's not a left bundle branch block, then you have to kind of go, okay, well, maybe it's VTAC, okay? And for the most part, you'll be able to kind of see in the 3 lead that it's going to need more investigation, right? Because even you look right here, right? Leads to 1, 2, 3, you know, if you usually end up printing out lead 2, right? You're like, something's going on right here. Something I was not expecting. I was hoping for like that cute, sexy one, right? So now also, so lead 1, right, is upright. Lead 1 is upright. Over here in lead AVF is a negative deflection, right? So what is my axis deviation here?
Left.
Yeah, if you're really clever, you saw that right there also, okay? So another thing that is really useful when you're looking at your EKG printout is a lot of them will tell you PQRST axes, okay? So if you remember that your normal axis is positive 90 to negative 30, and I know it says 0 here, but you have a little extension up to negative 30. And then you see here that your QRS, which is a second part, that axis is negative 56. That also gives you a clue that you're over here in the left axis. Okay? Questions, thoughts, concerns, recipes?
Nicole, where's the ST segment on B1, B2, B3? Because that,
good question. So when you have a left bundle branch block, it's a little more difficult. Come on, a little more difficult to pick out a ST elevation MI. But if you look, let me see if I get a good one. Here's V4 because it's kind of just cleaner, right? So your QRS comes down, your J point's right here. Okay, see that kind of like transition from like one to the next, right? It kind of goes like that. That's your J point, which means that this is your T wave, which is you don't have a really clear ST segment because it just kind of goes from your J point to the T wave. Let me see. We're going to skip ahead and I'll come back just because it's pertinent. So we use what's called Sgarbossa criteria in the presence of a left bundle branch block, because I have a feeling that's kind of where your question was going. So if you looked at that 12 lead, right? So it kind of looked like this, where you have your QRS goes in one direction and the T wave goes in the opposite direction. If you have here for rule 1, if you have your QRS going in one direction and then the T wave also going in the same direction, like over here, like in the same direction, that's usually a good sign that the patient is having an MI, as opposed to, see right here, they're having an MI as opposed to it just being a regular old bundle branch block. Another rule is that if you have, instead of this like very traditional looking QRS goes one way and then you have the J point above and then the T wave, if you have a depressed J point, right? So here's your, I gotta get my hand in a good position to draw. Here's your isoelectric line, right? Kind of hanging out right there. Your J point here is a good indicator that, and this is in leads V1 through V3, This is a good indicator that the patient may be having an MI. Now, you also have this other rule where, again, here's your isoelectric line, and your J point is more than 5 millimeters away. Okay, so let's go back. Hold on, see if I'm having an issue with the whole back and forth thing today. Okay. And here's your isoelectric line. Nope, I'm not drawing.
You're purple now.
Oh, okay, hold on. I'm gonna pick a good color so you can see. Here's some blue. All right, so here's your isoelectric line. And here's your J point, right? So that's 1, 2, 3, 4. 3 to 4 small boxes, okay? Which indicates that there's no issue in, the way that that's laid out. If you look here, which is a little harder because you have that. Here's your J point. All right, so you got 1, 2, 3. I'm going cross-eyed, count little boxes. 4, 5, 6. Okay, so there might be something going on here, but you need to roll it across. 1, 2, 3, 4. So you have just an isolated area, right, or isolated elevation here. Okay, that's not, it doesn't end up being indicative of anything because it doesn't have all of the criteria. Like you don't have contiguous leads with more than 5 millimeters of change. Does that make sense?
Yeah, it does. So if like that ST segment isn't continuous throughout all the beats, could it be like angina?
Yes. Yes. So it might be that there is like a small level of injury going on, or ischemia going on. Excuse me. It might be like a small level of ischemia, or it might just be that you're using collateral circulation in this one area. There's a number of different things, or it could just be like, that part of the heart is a little grumpy. It could be like a vasospasm. Ugh, throwing everything on the floor here. All right. So we talk a little bit like the axis deviation. So now we're going to talk about how that will help you in the event that you have a patient who you're like, is this VTAC with a pulse or is this SVT with aberrancy? Okay. So some rules when it comes to determining VTAC. Okay. Traditionally, these are hold on, let me pull that. Oh, for the love of God. I'm having a moment, guys. Apologies. So these are a number of the rules that you will see with the 12, when you do a 12 lead, if the patient is in fact in VTAC. So the number one rule that's really easy to remember, that's all the way here down the bottom though, all your precordial leads will be positive or negative. Okay, so see how you have negative, 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 positive, biphasic, positive. You should already be kind of thinking, I don't think that this is VTAC. Okay. Traditionally, you will also have a negative QRS in lead 1 and lead V1. Okay. While the QRSs are positive in leads 2 and 3. Okay. So if all of those criteria don't fit, which right here, right? This is a negatively deflected V1, doesn't fit here. So this criteria doesn't work. Kind of going back to all precordial leads will be facing the same direction. V1 and V6 should both be positive and either have a single peak, which I always joke that it looks like a ghost giving you the finger, which I'll show you in a second. And you'll see a lot of the dynamic, when you guys do the dynamic EKGs, the VTAC kind of looks like if it was a ghost, like a Pac-Man ghost giving you the finger as it went by. Or you'll see one of these other issues or kind of hallmark signs where there's a taller left rabbit ear, or the RS complex has like a slurred S. So like, you know, we talked about that slurred S, which is kind of slurry down here. But again, it doesn't fit this criteria either because your V1 is negative, so that don't work. Leads 1, 2, 3 are negative, so lead 1 is positive, so that one doesn't work. Lead 2 is positive, that also doesn't work. And lead 3 is primarily positive, so X-nay on that one. And V1 is also negative, so it doesn't fit that criteria. Now you have an extreme axis deviation, so let's look right here, right? Lead 1 should be positive, which it is, and lead AVF should be positive, which it is. So everything is telling us that there's no axis deviation. There's a normal axis deviation. There's no other signs, so it doesn't fit any of these other criteria to be VTAC. So as far as I'm concerned, this is aberrancy. Okay, this is an SVT, right? Because if you look right here, one box 300, 2 boxes is 150, so this is over 150, probably around a rate of 180 or so, right? So this would be SVT with a bundle branch block. That's what aberrancy is. We're meaning there by aberrancy. So now let's investigate another EKG. And these are things that you're kind of going to get a little more experience with as you start, as I said, as you start to look at more EKGs. But there's definitely, there's been times when I've walked into a cardiologist's office and the guy is going, he's in VTAC, and I'm like, you sure it's not SVT with aberrancy? Because it doesn't look right. And then, you know, you look a little more carefully. You know, this is what happens is people start to see this like really rapid, really wide complex, and they start to panic because they immediately think it's VTAC. This is when you have to immediately treat a lethal rhythm, but you also have enough time to make sure that that lethal rhythm is appropriately diagnosed, because you can't just, throw medication at the patient without having a good idea of what actually is going on, okay? So, we're doing this again. Haha, okay. So, going back to our criteria. Okay. Hold on, let me get my little sticker. There we go. Okay, so first rule, leads 1, 2, and 3 are negative. No, negative, negative, and negative, okay. And V1 is positive. All right, so that's our first criteria. Check. Is there an extreme axis deviation where AVR is positive? Uh-oh. And leads 1 and AVF are negative. Well, 1 is negative, and AVF is still negative. So if you look here, negative in your axis deviation, right? Lead 1 is negative, lead AVF is negative. This EKG is here in this extreme right axis. So you should already be making this face on the ambulance. As I like to tell my patients, like, do you see my face? Do I look like I'm concerned? Then you shouldn't have to be concerned either.
Yes.
Yes. Until you see the concerned face, you don't have to be worried. All your precordial leads are in the same direction. All right, so we got a positive here in V1, got a positive in V2. It's primarily positive here, primarily positive in V4, but a little more biphasic, I call that up and down here, and negative in V6. So doesn't 100% fit that criteria, but we've already got 2 other criteria that it's qualifying under. So let me clean this up a little bit for y'all. Are V1 and V6 both positive? No. But you do have that slurred S, right? Look at that. That's what I'm talking about with a slurred S. Like this QRS complex went out and it got drunk, right? It's having a lot more fun than the rest of us. Negative QRS in lead 1, all right, check. And V1, no. Positive QRS in 2, no. And 3, no. Okay, so we've hit 2 of our qualifying criteria, right? Where you have an extreme axis deviation and you have the leads 1, 2, 3 are negative with a positive V1. So would you call this VTAC, or would you say that this is aberrancy, SVT with aberrancy? Crickets, hello.
Aberrancy.
We just went through the criteria.
I'm going with VTAC on that.
Thank you.
VTAC, I'm kidding.
This is most likely VTAC, okay? So if you also look right here, remember I said it looks like a ghost giving you the finger? Oh, that's terrible. Here, try again. Here's a ghost, and he's giving you the finger. Or a high five in this case. Maybe V6 is a little better for the finger, right? See this, if you look at this rhythm strip here on the bottom, that very even kind of looping morphology. I'm having like a little stroke, sorry. Like very even morphology that you can see here, that is also usually pretty indicative of VTAC.
Nicole, so if this rhythm, if it falls in any of those criteria, even if it's just one of them, the likelihood of it being VTAC is greater, no?
Yes, 100%.
Gotcha. Okay.
And
so precordial leads up or down.
Yeah.
If they're all up, VTAC. If they're all down, VTAC.
Yes. And sometimes it's hard to see, like right here, it's hard to really, hold on. It's hard to really tell in your precordial leads here with like where the, also look, if you look how fast the rhythm is, right? It's like a rate of about 150. Here's your QRS, right? 1 box is 300, 2 boxes is 150. You're not getting a really clear isoelectric line, so sometimes it's hard to determine where the majority of the QRS falls. Right, so I'd say the isoelectric line's like right about here. So the majority of it is a negative deflection. But if you kind of look at it the other way, I don't know, it's hard to tell. You know, that's why, you know, sometimes you'll have a really clean, clear looking EKG, and sometimes you'll have a little bit of a mess. But yes, if it fits one of the criteria, then it is highly, highly likely that it's VTAC. All right. First, knee-jerk reaction to VTAC or SVT.
SVT.
Why?
The QRS is narrow. There's no present P wave, and it's fast. It's above 150.
Okay, good. So your rate, right? Your rate, you're definitely above 150, so it's going to give you that SVT or VTAC vibe. You do have a much more narrow QRS than you do, than you had with the last one.
I think that's why.
Okay.
Kind of wide, right? Yeah.
Good. And now look over here, right? Your lead 1 as a positive QRS, your AVF is a positive QRS. You're over here in a normal axis. You have a negative negative, biphasic, kind of biphasic, positive, positive, right? That's a normal R wave progression. That's not something funky that we saw in the last EKG. What else about this makes you think maybe more aberrancy?
You got V3. You got some bunny ears and AVL also a little bit.
Good. Good. AVL, right? See, there's a little bunny ear there. Even here, you can't really see it because it's a little bad of a photocopy. You got some notching here. You got some notching here. Is this a left bundle branch or a right bundle branch?
Nicole, I'm guessing right bundle branch.
Yeah, I was gonna say I'll
Yes.
go with the right.
It is.
Because you have.
Go ahead.
I was just say you have that in the bunny ears. You've got that first spike being taller than the second.
Mm-hmm. Yep.
And V3.
Yep.
And then you have that kind of slurry
that's the
at the bottom.
Yep, that's slurry S wave. And then also, if you want to do the turn signal right here in V6, if you have an upright QRS, you put your blinker up. That's a right bundle branch block. That was not the eraser. Just doodling now. So good.
And if you have a left bundle branch block, would the EKG be wider?
Yes.
Because the left ventricle is stronger.
Yes. You will see a little more widening in a left bundle branch block than you will in a right bundle branch block. Like, you know how we talked about PVCs and how they're kind of wide and bizarre looking?
Yeah.
Their left bundle branch blocks look a little bit more like PVCs, which is why they're commonly confused with VTAC. Cool. Good job. Awesome, guys. So now we're going to talk about the SVT segment and T-wave changes that you're looking for in a 12 lead when you're trying to diagnose like an MI or something, an injury or angina, or all of these things can give you different clues, okay? So, T-wave changes are pretty much the number one thing that we are looking for. If you do happen to find an EKG that has a very symmetrical T-wave, right? And you can really kind of see it. Hold on, let me get my little sticker. I keep hitting the wrong button. Right here, right? That's terrible. See how very symmetrical that T-wave is, as opposed to that tradition where you see it kind of go up and then come down really fast. That is usually indicative of what we call hyperacute T waves. Hyperacute T waves are like the first warning sign on an EKG that shit's going sideways, okay? That the heart's going, excuse me, I do require a little more oxygen than you're providing me, and I'm very upset about the service here, okay? Yeah, it is the Karen of T waves. So while it's over here asking for the manager, this is where you're like, time to throw some aspirin at it, okay? So there's a lever of other T-wave changes where we're just going to kind of stick with one or two that to kind of give you an idea right now that are going to be indicative of a progressing situation, a progressing MI. Had a patient once, a guy was a diabetic. He's sitting at home and he's going, I'm having a hard time breathing. I walk down to the corner store and back like I usually do. Usually I get short of breath, but I sit down and it goes away. And right now, it's just not going away. I'm like, all right, well, what else is going on with you today? He goes, I'm having this like 2 out of 10 jaw pain. And I was like, diabetic, new onset of ongoing shortness of breath, and jaw pain. Do the 3, do the 12, and no, nothing popped up, right? Looks okay, but his T waves were a little symmetrical. And I'm going, my partner, I'm going, it's going to be a STEMI note. And he goes, I don't think so. I'm like, oh, yeah, I think it is. So we chair him out. We get him into the truck. We lay him down. We get him comfy. And he's not complaining of anything having changed. And I'm a huge fan of numerous 12 leads because things change, especially in the elderly, especially in cardiac conditions and things like that. Things can change rapidly. So after we get him comfy, I hit the 12 lead button again. It prints out and pops acute MI suspected. And he went from having hyperacute T waves to looking more over here. I know this is the eraser, but he was here. He had full blown ST elevations. And I was like, call medical control. We're going to Jamaica. Not that we weren't going to Jamaica, but so he ended up having a few stents placed, but he had no chest pain. He had no other like indicators or the quote unquote classic signs of acute coronary syndrome. You always have to be suspicious with your elderly, your women, and your diabetics. Always keep that in mind. Come on.
About fibromyalgia.
Fibromyalgia also, yeah, because it can definitely cause significant damage to the nerves, and that nerve tracking isn't, you won't have that right appropriate pain response. But fibromyalgia is an autoimmune disease, and about 80% of autoimmune diseases are found in females, so it fits under your female criteria also. But yes.
Now, what about somebody, say, with pinched nerves or chronic pain?
It depends. So depends on where their pinched nerve is, because a pinched nerve has a very specific tract that it follows. So if they're having like a visceral cardiac pain, that will be a completely different pain from what they're used to experiencing. Because usually a pinched nerve gives like that pins and needles, that paresthesia, that, or just like discomfort, like that almost like restless leg syndrome kind of feeling, where this is like usually the traditional cardiac pain is a pressure or an intense pain. So it won't feel like their normal pain, because again, it's not the same nerve tract as the nerve tracts that you have coming out of your spine. It's a different set of nerves. So the pain does feel slightly different.
Okay, so now so women present differently, right? It usually goes to their armpit or something like that. They don't get the typical symptoms that like a male would.
So interesting topic of. So hold on, we're gonna stop this share for a second, and we're gonna have a little heart to heart. So all of the studies that they've ever done on chest pain and cardiac pain has been done on males. They literally have never studied chest pain in women, because women have historically been quote unquote too difficult to research because of the hormonal influxes that we experience on a monthly basis. So research has not studied women. So when we say, oh, it's the traditional pain, it's the traditional male pain. Women may or may not experience that. There has been studies that when women experience a cardiac event, the number one symptom that they experience is fatigue. They will be like, I'm just really tired. I don't know why I'm really tired, but I'm just really tired, okay? And it's usually up to about a day in advance, okay? So like the day before, they'll maybe wake up and like, kind of fatigued, maybe a little short of breath. I'm just not feeling well, okay? And they may never, ever experience chest pain. They might have a little nausea. They might be dizzy. They might have some like just odd feelings, but chest pain is not one of the top like 3 symptoms that women actually do experience when it comes to having a heart attack. But yes, when it comes to women, you should just kind of take anything like that kind of more seriously, because and a lot of women also get the, well, she's just hysterical. She's having an anxiety attack. She's having pain. Whatever, it's not real. It's all in your head, which is usually what kind of presents that disparity between how women receive healthcare and how men receive healthcare. Because if a man's like, I'm in pain, it's immediately assumed that, oh, he's telling the truth. He's a man. He can't handle pain. Or if he's too macho to admit that he's got pain. But women are expected to just, well, it's just part of your natural cycle, right? You have pain every month with your period. Why would this be any different? So this also was part of the reason that delays women from seeking medical care, is because they're like, this might be my uterus. Might not be. I don't know. I'll wait a day and see if it gets better. I'll take a Tylenol. I'll take a Tums, right? And it's not, right? Epigastric pain is another popular one that women experience. Men also experience that one. It's kind of like a 50-50 on the symptoms for coronary issues. But yeah, I guess to kind of answer your question, like, just if you have a woman who's like, I'm having crushing chest pain, definitely 12 lead. But even if she's like, I'm just kind of tired, I don't feel good.
So what about a pre-diabetic with herniated discs in the cervical or thoracic spine?
Absolutely. We don't see why you wouldn't do a 12 lead.
Nicole, what's the reason again for diabetic presenting with the masked symptoms or lesser symptoms again?
So sugar is a very large molecule, and it causes a lot of damage in the body. So no matter how well diabetics do try to manage their sugar, they have these peaks and valleys that normal people with a functioning pancreas don't have. So as that large damaging sugar molecule goes, barreling through the body, it causes a lot of nerve damage. So those nerve tracts that patients normally have that pain, it's not as heightened of a sense or a sensation that normal nerved people will have.
Thank you.
Mm-hmm.
Also regarding MIs and like how they show up on the EKG, particularly for like if you get it for a younger person, I would say you should suspect probably maybe like even myocarditis or something like that.
Yeah. So pericarditis is one of the thing. Pericarditis, myocarditis is like they know, like they're in extreme pain. Myocarditis is extremely painful. Pericarditis. Yeah, pericarditis also extremely painful, but the EKG changes are like there's like that hallmark sign where you have just global elevations throughout, where you're like looking at it going, is your heart exploding? Lord, I hope not, right? So yeah, you'll see that myocarditis can be a little more insidious about the EKG changes. Depends on where it is. Usually myocarditis it's more likely to cause valve issues. So like if you're potentially listening to heart sounds, you might experience hear like regurg or
I have afterwards I have regurgitating like valve.
Yeah.
So
yeah, it does a lot of damage to the valves.
So I had that and pericarditis.
You're just like, what, were you going for like the 2-for-1 special, like buy one get one free?
It was just a weird thing. I was like 19 years old. It's so weird.
That is weird. That's unusual. It was probably, let me guess, viral.
Yeah, because it started out like a really, really, really bad sore throat like 2 weeks before, and then like the worst I've ever had, and then it went away, and then I was having like just random like chest pain and like radiating like my upper, down my arm, jaw, whatever, and I was like, this is really weird, and it would like go on for like 5 minutes, and then I told my dad, he was like, you're just growing. It's probably gas, son. It's probably gas.
Definitely gas.
And I was like, he's like, we'll make a doctor's appointment. And then I go to the doctor's appointment and do an EKG, and they're like, you are going to the emergency room right now.
Here's a free trip. Oh, Lord. Question. Did you have any sort of dental procedures done prior to having that issue?
I mean, probably. I mean, I was 19, so I mean, I've had my wisdom teeth pulled out. I've had just other teeth pulled out, so for overcrowding. So
any sort of dental procedure. So even just like going and getting a regular cleaning can open you up to all sorts of various heart infections. Because there's like a straight shot from not only your mouth to your brain, but your mouth right to your heart. It's like they just take the freeway right down, and they're like, ooh, this valve looks nice. Let's set up camp here. So just things to keep in mind is it may be a good thing to ask if you have a patient who's experiencing chest pain, especially chest pain with a fever. Have you had any recent dental work? Because a lot of patients go right to the dentist. They don't think anything of it, right? They get a cleaning, they go home, no big deal. The older you are, they usually put you on antibiotics before they go in there and do anything for that reason in particular, because they don't want to like give you myocarditis from cleaning your teeth.
Yeah, I remember now afterwards, they're like, before you go see a doctor, like a dentist, make sure you like take some antibiotics.
You're like, oh yeah, I got some just laying around. No problem, I'll do that. So yeah, so that's your interesting stories for the day regarding.
I wish I still had my EKG from all that. I could
Yeah,
just give it to you
that would have
guys,
been
but
cool. I definitely
they're
had
probably
chest
still on file.
I definitely had chest pain a few years ago, and I went to the ER, and they're like, "We think you have pericarditis." I'm like, "Excuse me, there are no EKG changes consistent with pericarditis." And they're like, "Who are you? Why are you talking back?" And I'm like, "I'm going to a different cardiologist because I think you're an idiot." So
I feel
once
like
you start doing things, it's scary.
I feel like anytime Nicole goes to the doctor, she's just like, "No, you're wrong."
I had a doctor ask me, and we're going to talk about this issue later on. I had broken my hip 2 years ago. I had a stress fracture, and he goes, "Do you have osteogenesis imperfecta?" And I was like, "Do you have a medical degree? Like, osteogenesis imperfecta. You know the movie Glass?
Yes.
That is osteogenesis imperfecta. You bump into something and you break your arm." Like, I was like, I'm 30 and I'm not like, I have like a full grown arms and legs. I don't have osteogenesis imperfecta. Patients who have that
Wow.
have often like very like underdeveloped limbs because they're broken so often. And I was like, you're a moron. Like, I'm
Where
not
did you
allowed
get
to
your
go
degree?
unsupervised. Yeah. Yeah. So now I tell that story every time I go to a doctor. I'm like, there was this guy once who asked me if I had osteogenesis imperfecta. And they're like, what? I'm like, yeah, I knew what that was too. Dumbass. Anyway, let's back to 12 leads, unless anyone has any other questions. Cool.
Nicole, are
Yeah.
you gonna talk about NSTEMI?
Yes.
Like okay, cool.
Yep. I got you, Joni. All right. So the most traditional, as Joni already brought up and gave me a little preview, there's a difference between having a STEMI, where you have EKG changes, and an NSTEMI, which is a non-ST elevation MI. STEMIs are traditionally associated with what we call as a transmural infarction. Transmural meaning across the entire wall of the heart, right? We do murals on walls. So trans being across, mural meaning wall. So you're taking this, I gotta get my little sticker back, or my little draw guy. So you're taking this injury and it's going all the way across this wall. As it goes across the wall and causes ischemia, right? And then it causes injury, and then it causes infarct. Okay, those are your 3 stages. So as it starts causing injury, which is usually like this little tiny bit right here, and it's like, oh, this kind of hurts, right? You actually will have T-wave depressions. So you get your boop, and then your boop, and then instead of your T-wave coming back and going this way, oh, I erased too much. It goes down. I'm going to go down here. It goes down like this. Okay. This is what you traditionally will see with patients who have stable angina as well. Okay. They'll have this little inverted T wave. It goes the wrong direction. You're like, oh, well, okay. And you actually might see it go back to being a normal EKG if you give them aspirin, you give them nitro, you give them some oxygen. That injury will go away really quickly. Okay, all on its own. It's not a full occlusion of the vessel. There's still adequate blood flow going if they're at rest. The second they start pushing it, their heart's like, yo, bro, chill out. So once you get to the injury part, these cells are screaming, right? This is like a bigger area, right? So now this first part was an injury. And then as the blood flows continued to be limited, it becomes ischemic, and then this part here is injury, okay, until this middle part is fully infarcted. It's dead. You will not get this back. Up until like the injury and the ischemia parts, if you reintroduce blood flow to the area, usually via stents, this will heal and the EKG will go back to being totally normal. Those stubborn patients who are like, I'm having some chest pain, it's not too bad, right? And they don't ever go to the hospital. If they rest this part here, the injury and ischemia might start to heal itself, but anything that's been infarcted, this really black dead spot, turns into what we call a pathological Q wave, and that's down here on the EKG, right? Let me just clean that up a little bit. So that ends up being down here on the EKG. A pathological Q wave is more than one little box large, okay, wide, okay, plus one wide. Even after the ST segment comes back down to here, this, you see the difference? So see the normal Q wave, like a little like idiopathic Q wave, it's cute, it's sexy, it's teeny tiny, versus this one here where it's like big and wide and broad. Again, this is part of the issue where you're saying this is not creating a vector, right? It's not pulling electric, it's also, if it goes all the way across, it becomes like a window. Okay, and keep that in mind because we're going to elaborate on that in a little bit. It becomes a window right through the heart muscle. Okay, so you can, if you put like an electrode here and you're looking over this way, you're not going to see anything here because there's no electrical activity. Instead, you're going to see over here. Okay, it changes the whole way that the EKG looks, and will ultimately be very significant on when you're diagnosing it, okay? Oh, fantastic. It went without me having to fiddle. So, the rules for the differences between STEMI and normal, okay? If you have a patient who's complaining of chest pain, right, they sit down, they take their nitro, it goes away, and you have no conclusive findings on the EKG, you can sum that up to being just ischemia, okay? If you have some like T-wave inversions, you have a patient who's got chest pain that lasts longer than 20 minutes, especially anything that's longer than 20 minutes, especially after like nitro and aspirin, you're here in the end STEMI, okay? If you don't have any elevations, you're here in the end STEMI region. So they're still experiencing injury. It's just not changing the EKG because it's not a transmural artery that's occluded, okay? It's more focused. It doesn't have as much of a spread across that heart wall as you would think, as a STEMI does. It's much more isolated. So a STEMI is, again, it's an injury. You determine that it is a STEMI if the J point is elevated above the isoelectric line 2 millimeters or greater in leads V2 or V3, or 1 millimeter or greater in the limb leads in 2 or more contiguous leads, okay? So we talked about contiguous leads a little bit the other day, right? And we'll briefly review those in a moment, but I'm going to talk about this right here really quick, right? So we talk, hold on, let me get my little stick back. Go away, no, come back. So in regards to talking about, right, here's your ST elevation. This is your injury. Here's your isoelectric line. There's 4 small boxes between the isoelectric line and where the J point appears. This, if you found this pattern in 2 or more contiguous leads, you'll be calling a STEMI note. Here's your isoelectric line. Your J point is below, which means it's an ST depression, okay? This would potentially be considered an end STEMI, okay? Alternatively, and this is, we're going to go into this a little more in depth in a few minutes, this could also be indicative of a Oh my God, I'm blanking on the phrase. Hold on, I'm blanking. Oh my gosh, tiny stroke. Reciprocal change. There we go. Tiny stroke. Apologies. So that could be a indicator of a reciprocal change. And again, we'll talk about that in a little bit. So if you look over here, again, you have your J point is well above the isoelectric line, and which indicates here you have V2 and V3 that you're looking at. Those are your contiguous leads. You have more than 2 millimeters of change, which is indicative of a STEMI. Some more pictures, just, I don't know if, if it helps you having different pictures, because I know sometimes it helps me. Having the way people explain it with different pictures is sometimes more helpful in one way than the other. So the only thing I'm going to say is here in the middle, they talk about the difference between, they put injury up top. These, like, injury and ischemia should really be switched in terms of the progression from one to the other. Yeah, ischemia will have inverted T waves. Injury is at ST elevation. And then you have your pathological Q with an ST elevation and an inverted T wave. Okay. So moving on. Maybe I'm having a moment. There we go. So another little thing that we're going to talk about, not to make it confusing, but
Nicole, I'm sorry. On the last in the last one, to measure the QRS in the Olden part, you wouldn't measure it at that isoelectric line just before that dip. You wouldn't measure it there then, right? You would measure it at the dip.
for which one? I'm not
The
sure.
picture that says Olden part.
Okay, in the middle on the bottom.
Yeah.
So
so for example,
go ahead.
No, because like if you were to measure it from the beginning, just before that dip, the Q wave, right?
Mm-hmm.
Just before that, and then to the S, that would be like greater than point. What is it? 0.12. Or do you measure it? Or do you measure it at the dip?
So you would measure. Hold on, let me pull up the son of a bitch. So you're going to measure it from where it kind of starts coming down, so you can kind of see the come on, right, draw, see the line right there, and then where it comes back to the isoelectric line. So that's where you're measuring your width for the one box, and also
for the QRS, right?
For the Q wave alone, right? Because the Q waves are the pathological Q waves. And then you're also going to measure from the isoelectric line, and then down to the bottom where it turns around again. Does that make sense?
Okay. Yeah. What about measuring the QRS, like the length of the full QRS, from where to where?
Like the height or the left to right?
No, just to determine if it's not a left or right bundle branch block, just to make sure it's within the 0.12.
Okay, so you're going to measure from where it goes down to where it comes back to the isoelectric line.
Gotcha.
Cool.
So
good question.
kind of looks like it's greater than 0.12, right? So these old infarcts would always have a QRS that's greater than 0.12, maybe?
Not always. Not always. I think they exaggerated this a little bit to kind of give you a good view. But sometimes you'll just have like a really big QRS or just a big Q wave, which is like a bigger than one small square, but the rest of it is tighter. Usually when you have ischemia, it does kind of broaden the QRS a little bit, but it also depends on if an intervention was took place or if like how the heart healed. Because if it started to have like infarct at the further outreaches, which is why you would have a Q wave, depending on how wide that area is going to kind of determine the width of the QRS complex. Also, if it happens to be an MI in like the septum, where that electrical, that bundle of His and the two bundle branches go through, if it happens to be there and it damages the electrical conduction pathway, you will have a bundle branch block secondary to that MI.
Gotcha. Thank you.
No problem. Good question. All right. So a lot of times you'll do an EKG on like a younger person and you'll see something that looks a lot like it might be an ST elevation. And you're going to be like, oh my God, you're having a heart attack. And the patient's like, I'm 20 years old and I'm not having chest pain. Like, I'm just having some shortness of breath. And you're like, oh my goodness. It could be what we call early repolarization. And a lot of the time the life pack or whatever will pick up on it, okay? So in the event that you're like, I'm not sure, this looks like it's elevated, which you can't really, you can kind of see here. Let me get my little, whoever pointed this out to me, thank you. Here's your isoelectric line, and I'm sorry, this little guy's super blurry. Here's your isoelectric line, and you look here, and your J point, which is kind of hidden under the smiley face, is here, right? And it's going up this way. And that's more than 1 millimeter. That's 2 to 3 millimeters of difference between the isoelectric line and the J point. If you have, again, this kind of very concave smiley face look, it's most likely early repolarization. And again, this is going to also be determined by your patient presentation. So like if you have a patient who's like, I'm having crushing chest pain, maybe you should just not think of it as early repolarization. It's more likely a problem. If you have your isoelectric line here and your J point is elevated and the T wave goes directly from the QRS up and makes a sad face, that's a hyperacute T wave. This is indicative of an MI. Sad face means stents. Happy face means you're young and you're just repolarizing faster than you really should. Another view over here, right? Not a good sign. Not a terrible sign. Just things to keep in mind that you will see these. They do pop up fairly regularly, and it's usually pretty benign. The only exception to that is if you have an upsloping T wave with the J point under the isoelectric line. Okay, that is a MI equivalent. Okay, it gets the same management as a STEMI will. So this is the same person who you're going to give them aspirin and nitro and all of that jazz. So these are commonly seen in the precordial leads. Your J point will be down here so as opposed to early repolarization, right? So like if I do your early repolarization, you have your P wave, you have your R, and then you have up here, and it's upsloping and going into a T wave. Your J point's above the isoelectric line, okay? As opposed to here, where that J point comes all the way down below your isoelectric line, and then you have this tall, symmetrical, remember, symmetrical T waves are never a good thing, T wave, okay? So you want to make sure that if you do see this, that you want to make sure that you treat the patient appropriately, okay? This you can call and say, listen, I think the patient has De Winter's sign, okay? I don't, I think it's a STEMI. Commonly, this can also be a precursor for the Widowmaker, that LAD, okay? So you might always see that very significant looking ST elevation. Sometimes it will look like this. Let's go. All right, we talked about the Sgarbosa criteria, so we're not going to beat this to death with the stick. There is a Smith's modification to it that we haven't talked about. He just modified the rules a little bit. So rather than rule 3 being it must be elevation, it can also be depression. Whatever, it's the opposite. So if you have a positive QRS, it would be a negative. Also, if you have the QRS complex, the depression or elevation is more than 25% of the size of the QRS, because I know you're going to be counting boxes. That's Smith's modification to make it a little more precise. If you just kind of look at, you're going to be Googling this. I'm going to almost guarantee you're going to look at an EKG going, I think this is scarbosa, but I can't remember scarbosa. You'll be Googling this. You don't really see it very frequently. Most of the time your patients are like, you kind of just know, okay? You won't necessarily be going, oh yes, this is scarbosa criteria. Even if you call medical control and you're like, I believe he meets scarbosa criteria, they will also be Googling it to make sure that they know what they're talking about. So definitely keep it in mind. Remember the phrase. Remember, what I'm going to say that is most common is the first rule, where you have the QRS and the T wave in the same direction. Keep that one mostly in mind, so that, if you do see that, you're like, oh, that's totally not okay. So we talked about this already a little bit. We're going to review it because this is super important for identifying where the injury is on a 12 lead. So I don't know if you probably have heard of this, because it tends to be everybody's like first thing that they tell you when you're doing 12 leads. But the SALI method, SALI method of determining where the injury is, S being septum, ready? S being septum, A being anterior, L being lateral, so you have low lateral and you have high lateral, okay? And I being inferior, okay? That's your SALI method. AVR doesn't get enough love. Your contiguous leads, again, V1, V2, V2, V3, V3, V4, V4, V5, V5, V6, V6 and AVL and 1, okay? Because you might have elevations in V5, V6 as well as 1 in AVL, or you might only have one of, usually it's V6 because it kind of wraps around, but you can have V5 as well as 1 in AVL, okay? Same artery, see, it's your circumflex, okay? Same artery is involved. And the other contiguous is here is your 2, 3 AVF, okay? Just make sure, and then now, right, so your septum and your anterior wall are all provided blood by the left anterior descending. It's not infrequent that you will have a MI that extends to this entire region, this whole anterior septal wall, okay? And that's how we also name it, right? So if you have a MI that's affecting the left anterior descending, you can have a, I'm just going to write it up here, anteroseptal. You might have a anterolateral. Okay. You can mix and match, okay, but traditionally it's the contiguous leads that are being combined. But can you also have really bad, a patient with really bad coronary vascular disease who's having like an inferiolateral? Bueller?
Yes.
Yeah, thank you. I heard someone pop up and then
Yes.
go away real fast.
Yeah, that was me.
Right, so you can have any combination of these, especially if the patient is got extensive heart disease. Oh, come on. Oh. All right, and we talked about this as well. Brief review regarding AVR. It looks at the upper portion of the heart. So if you have any elevations in this area, okay, with maybe just an elevation in AVR and depressions everywhere else, it could be an occlusion of the entire left main coronary artery, which is the step above the left anterior. Okay, so if you think about, how they start to bifurcate and go down, the left main coronary artery is like the major part where the left anterior and the circumflex come off of. It also could be severe 3-vessel disease, where again that there's a really high and extensive blockage throughout, where this patient's probably going to need a cabbage. You also may see aortic dissections. Okay, they may present with bizarre complexes in AVR. Okay, so if you have a patient who they're like, I'm having that extreme chest pain and it feels like a tearing, and you're doing your part to make sure that you're taking care of your patient, and you do a 12 lead, you might see that there's some funkiness going on in AVR. Keep that in mind. Go ahead.
Just looking at this EKG, how would this patient like present? I've never seen anyone in a junctional rhythm.
So it depends. So if you continue to look at this, and it's a little hard to see, but you've got, because of the drawings, so let me pull this up. So this patient could be presenting in any number of ways, depending on their previous health status, okay? Patient could be like, I just don't feel good, right? Maybe they're diabetic, and they're like, I don't feel quite right. Or they could be having crushing chest pain, because if you look, right, so we've figured out, we have failed to find any P waves, right? So there's no P waves before the QRS. What's your rate? So here you have, this one's on the big box, so 300, 150, 100, 75, 50-ish, right?
57.
Yes, I know, 57. Danny, make me come over there. Okay, so we're going to cheat a little bit. Your axis is here, okay? What's your normal axis? Between what numbers?
All between -30 and +90. Yep.
Thank you, Joni. So you have a normal axis.
Oh, my thing was on mute. I didn't know it was participation here.
Yes, small participation. But if you look over here, here's your isoelectric line. You've got some elevation in one lead. Here's your isoelectric line. You've got elevation there. And here's AVF. It's a good clean one. There's nothing on it. You have some elevation here. Okay? So to me, this is an inferior infarct. Now, we didn't get to reciprocal changes, but we will momentarily. The reciprocal changes are caused by that hole that the injury is leaving in the view. Okay, so that lack of electrical transmission creates a window. So if you're looking on the opposite, if you're looking through the heart to the opposite leads, to the opposite side of the heart, where you have elevations, it's like a mirror verse, right? Where you have mirror Spock running around doing weird things, you will have depressions, okay? The reciprocal leads for the inferior wall, which, hold on, like the inferior wall, right, of the heart, the inferior being the bottom. Here's your septum, a little funky ass picture here. So directly opposite the inferior is the high lateral. So if you look up here in your high lateral leads, you have a depression. Right here, you have a depression. Not as noticeable here, but look at your low lateral leads. You have a depression in V5, and you have slight depressions in V6, right? So it's like looking through a mirror, where you have elevations on one side. That's a horrible arrow. You have elevations on one side, you'll have depressions on the opposite mirrored side. And we're going to talk about that right now. Does that answer your question, though?
Yeah, it does. I
Okay.
just want to know like how they would be presenting themselves. So it basically could be either or. It could be super like, I'm not feeling that well, or just like looking really wonky.
Really, really shitty. Yeah, they could be, and that's almost any patient. Like, they can be like chilling and talking to you. Like, all right, so I had this guy we picked him up. He had had a syncopal episode. He was an ambulance driver. He dropped off this patient at physical therapy and then promptly had a syncopal episode. BLS got there first. We pull up, and this guy is like white, okay? Like this background of the, the presentation, white. And he's diaphoretic. And we're like, oh, that's not good. And he's like, no, I'm fine. Like, do you have any pain? He goes, no, I'm just a little dizzy, right? And he is now bradycardic in the 40s, and he's having a massive MI, okay? He has like huge elevations. I forgot where, probably the inferior wall, because he was also hypotensive, severely hypotensive. And to kind of tie those two together, your, hold on, let me see if I picture the heart somewhere close by. Hold on. We're going way back in time, just here. So when that inferior wall, inferior wall is primarily consistent of down here, right? This whole bottom part. So when you have a significant damage to down here, you're tanking the preload. Okay, and as you tank the preload, your blood pressure also drops. Okay, so this is why when you're talking about managing MIs, if you have a patient who's dealing with an inferior wall MI, they say to be cautious with the nitro. If they are not in like a, because sometimes they might have enough heart muscle still surviving. If they don't have a decent amount of heart muscle surviving and you give them nitro takes away the preload, which drops their blood pressure, which means that if they already are kind of hypotensive because that side of their heart is damaged, you're just going to put them in the shitter. Okay, so this is why you're cautious. So we have this guy, we have him on the BLS stretcher, and he's not presenting with any chest pain. He's just chilling, right? He's just hanging out going like, I just don't feel great, having a massive MI. We get into the hospital and he's like, I don't want to do anything. The doctor's like, you're having a STEMI. We need to get you upstairs like now. And he's like, I don't want to do anything until my sister shows up. And he's like, dude, like you're not going to necessarily make it. And then he died. And the doctor went, oh crap. Dropped him into like the CPR. He was on the hospital bed. Dropped him with the CPR position and started doing CPR in this guy. And I'm like, that did not just happen. And it was another moment of the guy then sat up and was like, what happened? And then he was like, you just died. Can we do your procedure now so that you can live? And the guy's like, no, I need to wait for my sister. And I swear to God, I thought this doctor was going to slap him. I thought he was just going to like full blow just go, poof, what's wrong with you, you idiot? And then his sister showed up and went, what's wrong with you, you moron? And then he got stents. Like, but yeah, you can have patients presenting from like the diabetic having a STEMI where there's like almost virtually no symptoms to, I had a guy who was writhing in pain and being really dramatic looking about it, but he was also having a massive STEMI. So it really depends on their previous health status, right? Because if they can compensate well, then they're okay. Or they could be, if they're really sickly, they could be completely unresponsive. Like you really can have almost any range of presentations. So it's why you always have to kind of be cautious. And now that I've rambled effectively, when you're looking at your EKG, you need to know these reciprocal changes. Okay, so if you have ST elevations, I'll get my little pen back. If you have ST elevations in your lateral leads, the reciprocal, where you will see depressions, which confirms that it is an ST elevation and not you kind of having too much Red Bull that day, will be found in your inferior leads. Okay? They are directly across from each other in the heart, based on how we view it with the leads. Again, anterior lateral, your anterior wall is your V3, V4. There are reciprocal leads, but only if you do a posterior 12 lead. And that goes the same for your septal wall and your anteroseptal, okay? you need to do a posterior 12 lead to get proper reciprocal changes, okay? And again, we'll talk about that in a little bit. So that means if you have V3 and V4 added in, you're not going to have any additional reciprocal changes. This is just going to be your inferior wall again. And if you have an inferior MI, you're going to have lateral changes. Okay? Those are kind of where the majority of your reciprocal changes are found. Okay? To discuss, I think I have a slide. Hold on, I'm having a moment again. No. So in the event that you have significant depressions, okay? Hold on, let me just, and this happens every once in a while, right? So imagine you do an EKG and you don't have elevations anywhere, but in leads V1 through V4, you have depressions that look like this over here. Okay? And you're like, that's suspicious. You could take your 12 lead, right? So you have V1, imagine this is like a body here, and it's got an extra. V1, V2, V4, V3, V5, and V6. You can do a posterior where you take your V4, V5, and V6, and you put them around. You keep going. So you take V4 and you make it V7, which is the posterior axillary. Okay. Portion. And then you take V5 and you move it to mid axillary on the back. And then you take V6 and put it like just by the sternum, so like the sternum's right here, like the edge of the sternum. Okay, so, and this becomes V7, V8, that's a horrible 8, and V9. Okay, and then you press 12 lead again. The problem is the 12 lead doesn't know that you've moved your stickers, so it's still going to label it V4, V5, V6. So after you print it out, you got to like cross it out, be like, this is V7 now. And like you can even write on the top like posterior, okay? And to confirm that your reciprocal change is in fact a STEMI, you would see elevations in V7 through V9. Okay, so to fix this, septal V7 through V9, and okay, does that make sense? Now to take it a step further, you can also do a right-sided EKG or 12 lead. So I'll go back down to here, my little torso man. So right, you have V1, V2, V4, V3, V5, V6. If you have an inferior wall MI, right? We talked about the issues with preload. Okay. If you're concerned, you're like, I don't know if I should give this patient nitro. Okay, I don't want to tank their blood pressure. In order to confirm if the right ventricle is involved, you take the first thing you can do before you do a full right-sided EKG, you take V4, you peel it off, and you stick it under this nipple on the right side. And again, same thing, you print it out, and you see if there's any elevations in V4R, and you need to make sure you write that down, okay? And you need to also make sure if you call medical control and you're sending them a right-sided EKG that you tell them, hey, this is a right-sided EKG, because you can now, after you move V4, you can also move V5 and V6, the same, mirrored as it would be on the left side, you can put it on the right side, and see how much is involved. So if you have elevations in V4, you can continue to work your way around the side and determine how extensive that MI is. If you do happen to have right-sided involvement, that's a good time to not give nitro. or to not give nitro unless you have a solid line in place, okay? Because you can always fix it by adding a little fluid to kind of take care of that preload issue. I think we're going to have a better picture of that in a little bit, but I wanted to kind of talk about that here with reciprocal changes before we moved on. Questions? Well, I didn't hear anybody's brain explode, so I guess you're still with me.
Everybody's on mute.
Everybody's on mute, exploding quietly. All right, so let's talk about this EKG. Pipe up. Participation time. When you look at this EKG, do you go, oh no?
Yes.
Good. All right.
I see bunny ears, so it could be a bundle branch right off the bat. I see P waves.
Okay, so do you see bunny ears, or where is your T wave, and in the locations where you see bunny ears?
Bunny ears. And
V2, V3. It looks like bunny ears, but then again, there's no SC segment there. Oh, V1 has the SC segment. Oh, elevations.
Okay, so let's start from the very beginning. Do we have the super beginning? Do we have P waves?
Yes.
Okay, yeah, they're a little hard to see, but here's a P wave here. Okay, here's a P wave here. Are they associated with QRSs?
Yes.
Yes, okay, right? P wave happens, Q wave, QRS happens, P wave happens, QRS happens across the board. Good. Slow, medium, or fast?
Medium.
Yeah, that's a medium, right? All right, let's look over here. We got he's pretty close to a big box. 300, 150, 100, 75.
60s.
Yeah, he's in the 60s. Definitely in the 60s. So let's write that up here. 60s. Rate of 60. We have P waves. We have QRSs. They are together. Anything that jumps out as being suspicious?
Bunny ears.
Elevation.
All right, so let's go back. Are these bunny ears or are these elevations?
Yeah, lead one shows the elevations.
All right,
and
so
ABL and the depressions in lead 3.
all right,
Oh,
good.
these are elevated because you got the
Okay, so let's start with V1. There's your isoelectric line. I call that like a maybe 1 millimeter elevation. It's hard to see on this copy, obviously, but you definitely have what I would call a hyperacute T wave. Look at this one. It's also very, very symmetrical. It's like a big old P wave almost. Here's your isoelectric line. Let's count now.
Is this person with Parkinson's?
Say that again?
Is this person with Parkinson's? Because it's shaking.
No, that's just a little muscle movement.
It's like 2 full boxes.
That's like, so that's what, 5, 10? Well, here's your J point. So just under 10. That's like a 13 millimeter elevation in V2. That's a bad day. Let's start with that. That's a bad day, okay?
He's gonna die.
He gonna die. So here's septum. Here's your isoelectric line. Again, we have more than almost 2 boxes, because here's your J point. You have almost 2 full boxes of elevation here. Moving on to and this is anterior wall. Moving on to your next contiguous lead. Here's your isoelectric line. Here's your J point. Here's your sadness of your cardiac muscle. More involvement in the anterior. Next contiguous line. Here's your contiguous lead. Here's your isoelectric line. Here's your J point. That's only 1 full box. That's good. Lateral lead. Now, isoelectric lines here. Your T wave is in alignment, so this does not progress to here. However, you go look to your other lateral leads, 2 and AVL. Here's your isoelectric line. Here's your J point. That's 3 or 4 millimeters. Isoelectric line, J point again. So this is high lateral and high lateral. Now, we talked about reciprocal changes, right? Your high lateral, we don't have any reciprocal changes for your for your septum. We don't have any reciprocal changes for your anterior, but we do for your lateral and your high lateral. And that's here in your inferior. Hold on, I'm going to change colors real quick. It's going to be here. I hope none of y'all are colorblind. In your inferior wall. And a reciprocal change is going to be depressions, correct? So here's your isoelectric line. T wave is good, so that's okay. Isoelectric line. There's some depressions there. And here on AVF, here's your isoelectric line, and you still have some T wave depressions. So this is a STEMI, right? How would you manage this patient if I told you that his blood pressure was 110/70, no ED medications, and he had 8 out of 10 chest pain?
Aspirin.
Aspirin, 100%. Aspirin. Nitro, okay. Would you,
Big bore.
with a blood pressure of 110/70, you can do a large bore, 100%. Do you want to give an IV or nitro first?
IV first.
IV.
Yes, IV. Large bore if possible. I heard a little nitro. We're going to mix it up. Anything else you want to do for this patient?
Right side, EKG.
Okay, you can.
What did he say?
A right-sided EKG.
Oh.
O2.
So right-sided EKG would be more if you had elevations here in the where you have the reciprocal changes. What if I told you that
Oxygen, right?
oxygen? Okay. What if I told you his SpO2 was 100 on room air and he had no shortness of breath?
Still give him oxygen.
Mm-hmm.
How much?
Low flow.
Low flow?
2 liters.
Yeah, 2
Low
liters.
flow, you document 15 though.
Yes, there you go. Or you document that the patient refused the non-rebreather.
Exactly.
There you
Non-tolerated, you put a nasal.
Non-tolerated.
Not tolerated. Patient was put on a nasal cannula at a flow that they could tolerate, which happened to be 2 liters per minute, until our protocols catch up with us and we stop toxic oxygenating everybody. What else? Anything else you want to do for this guy?
Diesel therapy.
All right, little diesel therapy. Now, what happens if I told you his initial blood pressure, I'm going to change this color to green, his initial blood pressure was 70/40.
Take away the nitro.
Take away the nitro.
Elevate.
Would you put pads on him
Maybe.
if you think he's about to crash?
If you think he's about to crash, maybe, but what can you do to keep him from crashing?
Fluids.
Fluids. All right, so let's call it a fluid challenge, right? How much fluid is a fluid challenge?
Dump it all.
No. No.
Oh.
Go ahead. How much?
Like, oh, I'm on mute.
No, 500.
500 back, maybe?
Okay. So if you look at your so what would this be indicative of? He's got extensive damage to his heart, and he has say it again.
Cardiogenic shock.
Cardiogenic shock. So if you look at your cardiogenic shock protocol.
Trendelenburg.
Okay, Trendelenburg never goes wrong. seeing if anyone's really quick and pull it up.
Mm.
There is a amount.
500 push.
So the total you can give is 500.
Just kidding. That was silly. Ignore
No, the
that.
total you can give is 500, but it's split into two. So you can do a 250 challenge, and then if the blood pressure doesn't change, you can do another 250 challenge.
Mm-hmm.
Okay. What happens? You give him this 250 milliliters, and he starts having difficulty breathing.
I treat.
Okay. How would you treat? What would you do?
Well, you would lower the rate, and then you would have to adjust them to sitting up at least.
Okay, at the very least sitting up. Why would you suspect that after 250 milliliters of fluid that your patient is having a hard time breathing?
Fluid overload.
Yeah,
The fluid overload, he's probably in congestive heart failure secondary to this ischemia that's going on over here, this little sadness, right? So it's an acute pulmonary edema, most likely, okay?
CPAP.
So yeah, there you go. You could CPAP if you needed to. What other pharmacological ways?
Norepinephrine.
Say that again?
Norepinephrine.
Norepi, absolutely.
Pressure.
You can treat him with norepi. That's spelled horribly. I'm having a stroke. You can give it. So you could do norepi. You could do dopamine. Right? What is one of the concerns that you should have if you're giving a patient pressors while they're having an MI?
Bottom out.
Taking out their blood pressure.
No, you should be fixing that, right? You're giving them pressors to fix the blood pressure.
Just kidding.
You can overload the heart.
Perfect, right? You want to overwork the heart because as you're overworking the heart, what are you also increasing demand for?
Oxygen.
Oxygen, right? And if this heart is right here, this is literally a scream for oxygen. It's right. It's a scream for oxygen.
That's why you go with the norepinephrine instead of epi.
There you go, right? So you could use norepi. But either way, it's still gonna increase the oxygen demand. So you might want to increase your 2 liters. You also might want to consider calling medical control and saying, hey, he's in cardiogenic shock secondary to an extensive MI. I don't want to overwork the heart. Like, am I doing, can I give him dopamine? Should I allow permissive hypotension where you're only taking this 70/40 and maybe bringing it up to the 90s systolic? Okay, because at 90 systolic, your patient's not totally in the shitter, but you're also not increasing the oxygen demand to the point where you're going to cause more damage. Okay, good. That was awesome, guys. Any other thoughts, concerns on this patient before we move on to the next one?
That was like a mega code type of thing.
It absolutely could be. Yeah, a lot of these things they can turn into mega codes pretty quick.
I mean, Nicole, when I first saw the rhythm, I mean, and we didn't really talk much about clinical presentation other than the blood pressure. I would presume that this patient is really going to be probably in a lot of distress. They're going to look really sick. So, I mean, you have to be thinking measured response in terms of heart work overload.
Yes.
You can see that they're obviously the heart is dying.
Mm-hmm. It's literally screaming. It's literally
Right.
like, I need help. Good. All right. How about this patient?
Oh man, it's well, lead 1 is upright and AVF is upright. I had to look at that picture again.
Okay, so we need our
Elevations in AVF.
okay. So all right, so hold on. So let's start at the beginning, right? So do we have P waves?
Yes.
Okay, so here's a P wave. Here's another P wave. Here's a P wave. Are they married to your QRSs?
Mm-hmm.
Yes. Okay, they have a good relationship. Okay, so we have P's, we have QRSs, and they're married. Fast, medium, or slow?
Medium.
Medium. Okay, so we got, here's this pretty much on this big box, 300, 150, 175. So it's about 75. A rate. Okay. Now, that normal axis, right? Let's do this real quick. Your normal axis, you have lead 1 and AVF are both up. Abnormal axis, they're both down. Fill in the blanks for me, guys.
So they're both positive.
It's a normal axis.
Normal, yeah.
Yeah. But if it's a left axis deviation, is it my lead 1 is what, up or down?
It's up.
Up.
And AVF?
Is down.
If it's a right axis deviation, I've got lead 1 and AVF.
The opposite, so down and then up.
Down, up.
Good. All right, so here we got lead 1, it's positive, and lead AVF, it's also positive. Okay, so your axis is good. Now, I think Edward had mentioned that he noticed elevations.
I see something funky with the T wave.
Where?
Down on the V3.
Okay, V3. So we're going to talk.
And
we're going to hang on to V3. V3 or lead 3?
V3, and also as I look over at V3, that's the T wave.
Okay.
But,
So
but V3 as well. And just, I'm going to throw this in there. Maybe it's something, but on the 1, 2, and everywhere I can see the QRS, there's something funky going on with that. Yes. I mean, it's tight, but I can see some sort of break in it.
I think that's just a bad scan, honestly.
Okay.
Okay, so we're gonna hang on to lead 3 for now and come back to that in a moment. So let's look at our precordial leads over here, just because we can. What's our R wave progression? Got down, negative. Okay, it's not great. Biphasic. Okay, like it's supposed to be. Positive and positive. So R wave is okay. R wave progression, it's okay. Not perfect, but it's passable. Do we see any elevation? So here's my isoelectric line. That was terrible. Here's my isoelectric.
I see some ST elevations.
Yes or no? Sorry, yes?
No.
No. Huh.
No.
No.
Okay.
No.
Oh, right there.
Yeah, maybe a little bit in V6. So let me erase that.
And also in V4. A little bit. But
I would call that hyperacute. It's not quite elevated, but I wouldn't be surprised if it was going to go that way shortly. Definitely have a small elevation here in V6, like a 1 millimeter, but we don't see, because like it's kind of on a downslope. V5 is okay, and then we look over here at your other contiguous lateral leads. That's a really solid isoelectric line there, and you've got some depressions here. So I would call this a potential reciprocal. This is like a maybe bad. Maybe. Now, let me change this color real quick. Let's do orange. Here's my isoelectric line in lead 2.
You have slight elevation.
Yes. I call that, if you squint, it's 2 to 3 millimeters. Here's your isoelectric line in AVF. Again, I'll call that maybe 2. Now here's where it gets a little funky. You have a very low voltage QRS, like right here. Okay, let me just. Okay, so it's really hard to see your QRS. But based on where you line, if you like line it up with the lead above it, because these are all happening at the same moment in time, it's the same QRS complex, but just from a different view. So you line it up and you're like, all right, so here's my QRS, which means your J point is here, which means you have this hyperacute, slightly elevated, because we're going to just, it's maybe 1 millimeter elevation, right? And you're going to get some funky looking complexes like this. But if you look at the contiguous leads on either side of it, they both have elevations, so it's a good, strong possibility that this also followed suit. Okay? Now you've got your reciprocal changes here to match, right? Because remember, what part of the heart is affected here? What part of the heart is this?
Inferior wall.
Inferior wall, beautiful. This is your inferior. Okay?
Don't tell me this is a STEMI too.
Yep. This is also a STEMI. Would you give this patient nitro?
What's the blood pressure?
If I told you that this patient's blood pressure was 180, that's over
Absolutely.
90.
Yeah.
Absolutely.
Would you want to have an IV in place first?
Caution with the nitro and the IV first.
There you go. There you go. Like I wouldn't, like there's some patients who like, you see 180 over 90, you're like, here's like 3 nitro, woo! And they're like, I'm good, my blood pressure's now 178 over 80. And you're like, oh, well, that didn't work. But if you have an inferior issue going on here, you want to definitely make sure, and then you want to have that IV in place in the event that that 1 nitro could take them all the way down to 80 over 40. So
would this indicate an early start to the STEMI?
potentially, yes. Now, if I told you that this patient was having some mild chest pain, blood pressure 180 over 90, you sat them down, you gave them a little oxygen, and then you did another 12 lead, and this went away, would you call this a STEMI still?
Angina.
Perfect. Perfect. And that's sort of your delineating line, right? If the patient's like, I was walking and I have some chest pain and like, you know, and then you have like a kind of a not super, like it doesn't look like the last EKG, and then it just kind of looks like this, and you give them maybe some aspirin, and you gave them some nitro, and you give them some oxygen, and it goes away. That's more in the unstable angina realm than a STEMI. But if you sit them down, you give them some oxygen, and you do another 12 lead, and this starts to go up, and like up, and this T is going up, this J point just like, I'm out of here, and starts going up towards the other leads, you're full-blown STEMI. Okay? And this is why I like concurrent 12 leads, because it will really just give you a full-blown picture of what's going on with the patient, and it helps you kind of direct your patient care a little bit better. So going back to, will I give that last patient nitro or not? This is when you go and check your right-sided EKG before you continue treatment. Okay, we talked about that a little bit. Here's a better picture of that idea, where if you take your leads and you take V4 from the left side, or the left side, you move it to the right side, and then you take V5, you move it over, and then V6, and then print it out again. Just make sure that you label your EKGs on this side, that it's the right-sided EKG. So if you do, and you have like serious elevations in the V4, 5, 6R, this is somebody who maybe you want to be extra cautious, right? Because that's right-sided, right ventricular involvement, which means that if you give them that nitro, you can totally take their preload away. And then you're going to have to kind of rush and try to get a pressor on board to bring their blood pressure back up to where they need to be.
Nicole, are we going to be doing this reciprocal lead thing in skills?
Yes. Yes. All right, cool. And we talked about this as well. The posterior wall is just like one of those like edification things. I've lost my eraser. Where you need to know that if you have significant depressions in V1 and V2, which you kind of see here, right, that you can take those leads around to the back and determine if it is ischemia, or if these are, or if this is ischemia, or if it's reciprocal changes from an elevation in the posterior leads. Right, so that's the easiest way to determine. Right, you have a patient who's got chest pains, and in V1, V2, V3, they've got some depressions, and you want to try to make sure it's a STEMI and not just angina. That's how you're going to do it. You're going to take those leads around the back, right, continuing, like since V6 is mid-axillary, V7 is posterior axillary, V8 mid clavicular in the back or mid-scapular, and then V9 is medial scapular. Okay. I think that's our 12 lead. Yeah, that's it. Questions, thoughts, concerns?
I'm a little concerned right now, just in terms of the volume of the material. And I mean, I've just started in on the 12 lead section of the textbook, so you're a little ahead of me in terms of, there's a lot of information here. So I presume doing the review Wednesday morning, that's just a 3-lead review, that we can continue that process of just banging away at this, because this seems like it's really intense.
It is intense, but honestly, the biggest chunk is kind of just determining the underlying rhythm. And once you're familiar with the rhythms, and you're just going to pick this has an elevation. What part of the heart is that in? Oh, am I going to use my Sally and I'm going to label it? It'll come in steps, and you'll definitely be able to start piecing it together a little bit more. I will see if I can put together some 12 leads and like a little sort of like we did with drug math. I'll see if I can come up with a 12 lead practice thing for you guys.
Okay.
Sounds good.
The mod part is on the second.
Say that again.
The module for cardiology, that's on the second.
The module exam is on
August 3rd.
3rd.
Yep, August 3rd.
What do you think what we should be focusing on for this module? In reference, yeah. In reference to
identification, understanding what each complex means and how that complex is supposed to look. So some of those identification that we talked about, right? So like, how wide should a QRS be? Okay, how, if a QRS is wider than blank, what does that mean? Okay, stuff like that. You will have 25 EKG rhythms that you're going to need to identify. Your critical rhythms are asystole. If you can't figure out asystole, VFib, VTAC, and your heart blocks. Okay? No, have those down cold, and you'll be okay. And sinus rhythm. I think like everyone's kind of familiar with sinus rhythm. We kind of understand what what that looks like at this point, but have those critical rhythms down as well.
They wouldn't try to trick us and show asystole and then very fine VFib, would they?
No. Though, depending on who you're working with, fine VFib, asystole is 550. Danny, were you on that job where like I was working with our medical director showed up on a cardiac arrest, and he's like, "Is that asystole?" And I was like, "I don't know. It looks like fine VFib to me." He goes, "Let's shock it," and we did. We got a rhythm back, which was wild. So every once in a while, you know, little asystole might need some love. It's just really just fine VFib.
So Nicole, you raise an interesting point. So as I'm reading the material, and I understand that there's a progression in the electrical signals that we're reading from, let's say it goes to VFib, or let's say it's coarse VFib, that it goes to fine VFib, and then to asystole. Is that correct? I mean, is that what if asystole, we're seeing a late progression of heart, the heart dying or the heart stopping?
Yeah, 100%. That's exactly. It goes from this coarse VFib where it's like there's still a lot of electrolyte movement, right? And it's trying really hard to depolarize and all that jazz. And then it just goes down to fine VFib where it's like, oh, we're losing some momentum, and then asystole. Hold on one second. Hey, NYU Nicole. What's up? I'm good. How are you? James. Okay. I do believe he's correct. Let me call you back with that in about. Okay, I'll text you in like 5-10 minutes. Okay, no problem. Bye.
So if we were to stumble upon a stumble upon a course VFib, is there a time frame that we could estimate that person's been down for?
No.
Okay.
Because some people do progress a little faster than others, and it's a lot of different factors. So like if you have a significant electrolyte imbalance prior to going into cardiac arrest, and like that's the cause of your cardiac arrest, you might just, you might progress a lot faster because your electricity is off. Like, you know what I mean? Like the electrolyte balance is off. COVID, they were finding people were just dropping right into asystole. Like there was no progression at all. They were just like, do, poof, and that was it. A number of other things could cause significant issues one way or the other, depending on the pathophysiology in the background. But traditionally, if you show up, right, and you have a patient who's like doing that agonal breathing and they still have an organized rhythm, you get them on the monitor. Maybe they have a little VTAC, and then it goes into the coarse VFib, and then a fine VFib, and then asystole. Then that's the traditional progression.
Okay, so also I'm guessing now that if you're coming across, let's say you come across an asystole on scene, this is going to factor into how hard you're going to be working hard on the resuscitation, but whether or not you would call it.
So it depends on last known time, and they've done a number of studies. And I know that when COVID was really in the high outbreak levels of COVID, they changed the cardiac arrest protocols where if a patient's last known downtime was greater than 20 minutes, and they were in asystole, that you could terminate resuscitative measures, because there's been a number of scientific research that's found that once a patient is in asystole, they have a very, very, very low rate of functional capacity, like making it out on the other side without being a cucumber. It's like 0.5%. Okay, so that's like 5 patients in 1,000 might make ROSC, and then of those, another like 0.5% would have any neurological function. And usually it's the younger patients or patients who were electrocuted. Drowning and electrocutions are the two like asystolic scenarios where you would actually be like, we're going to try, because it wasn't brought to you by some other underlying cause.
Hypothermic as well?
Mm-hmm. Hypothermic, you have to work them till they're warm. Okay? Like they have to be warm and dead. which causes significant workload. And this is part of the reason that they're like, if they've been down for greater than 20, let them be, because the hospitals were at capacity. They didn't have ventilators to keep essentially a vegetable alive when people who were struggling to breathe needed these ventilators. Okay. So that was part of the reason, and then everybody lost their bananas because they couldn't wrap their minds around the fact that EMS was going to show up and let a dead person stay dead. Your brain dies after 6 minutes of no oxygen. If you've got 20 minutes of no oxygen, what are we bringing back exactly?
You really dead?
You're super dead. Like, it's not like the Princess Bride where he's like, oh, he's mostly dead. I've seen worse. He's very dead. So everyone kind of like lost their bananas on that one. However, if you have someone who has a witness downtime, if you have someone who's been receiving CPR from like a family member who witnessed them down, you are obligated to work that patient unless, of course, a DNR or a valid MOLST is produced. But yes, like, your cardiac rhythm can give you a significant idea of where the patient is. If you have VFib, that patient's relatively fresh. Okay, like, they are going to have way better outcome than if they're in asystole. But we start talking about, when we're doing cardiac management, that you need to also consider your H's and T's. So, is the patient hypothermic? One of your H's, right? Because if they're hypothermic, you start warming them up, they might come back to life. Like, they might start exhibiting like actual brain function, like being frozen. Your brain has a very low oxygen demand, your very low metabolic needs, so you can kind of hibernate in a chilly state for a little bit longer than if it was like hot out. Usually little kids also, like, you can kind of defrost them and they're like still okay. Same thing with drowning. You can kind of like shake them out and like wring them out a little bit, and like the little kids will be okay. The older you get, the less you hang on to all of those like compensatory mechanisms. So you're just like, I'm gonna wear those swimmies when I'm going out because I don't want to drown. But yeah, as you move through the progression, VFib is a relatively fresh arrest. If you have a patient who's in PEA, you have to start thinking, oh, maybe they're hypoglycemic. Maybe there's an electrolyte imbalance. Maybe there's a pericardial tamponade, right? Maybe there's something underlying that needs to be fixed in order for them to start living again. And a lot of the times back in the day, pre-COVID, PEAs you could not pronounce on seat. They would make you transport so that they could do a pericardial, drain or whatever. Like, they could,
Pericardiocentesis?
Yes, thank you. Couldn't think of that word. Pericardial centesis, or a chest tube. Maybe they had a tension pneumo, right? There's one of your T's that was causing the lack of cardiac rhythm, because you can still have electric moving through, but no mechanical. So yeah, it does give you a kind of a benchmark for what you can expect as you work up the patient.
Okay, thank you.
You're welcome.
I've had two patients that negative pulse, but I could still hear their heart going, like very faintly. What is that about?
That is serious either hypotension, or their heart was just like the electric was still going and they were still pumping, but it wasn't filling. So it could have been, brought to you by cardiogenic shock, where maybe the heart muscle was not effective, or serious hypovolemia. But yeah, it's a possibility.
I had a trauma lady. I'm sorry, go ahead.
Quick reminder, everybody, 8 a.m. review, Scott's 8 a.m. review, whoever wants to attend, Wednesday.
Thank you.
Highly recommend.
Will you be there this Wednesday, Nicole?
No.
Cole, when are you going to come hang out with us?
I don't know. Think about it. Any other questions or thoughts before we sign off for the day? All right, cool. So